Hi, everyone. I am Lynn Slosky, the Executive Director from ANAD, and I want to welcome all of you to what should be an incredibly useful and interesting and thought-provoking webinar called Telehealth Interventions for Eating Disorders, Do They Really Work? We're so fortunate to have partnered with Eating Recovery Center, who was graciously made Casey Talent available to us. And then we also have a special guest from Recovery Record, Jenna Tregarthen. And so we're really excited to talk with them. We'll have about an hour and a half total. We'll save the last 15 minutes for questions. Just for the first couple minutes, though, I do want to breeze through a little bit about ANAD in case you're not familiar. Hopefully most of you are, but our mission is to alleviate suffering and provide support to those struggling with eating disorders. We do this in a variety of ways, all through free support services. Again, these are all support services that are free of charge. Even through this COVID-19 crisis, our helpline is fully operational throughout the week. We have 26 online support groups, also throughout the week at a variety of times. Recovery mentorship, which is one-on-one discussions with friends who can relate to what it's like to go through an eating disorder. Our Grocery Buddies training. We also have a downloadable ANAD approach set of guides. And we are still planning on our professionals conference, which is set for September 25th this fall. We will be releasing our speaker lineup in a couple weeks, and we are still planning on an in-person event, but of course we will make the safest decisions possible in the next couple months. You can learn about all of this and more at anad.org, and then just click on the button for the COVID-19 crisis, and you'll find all kinds of online resources that we've compiled over the last few weeks. Special thanks to our webinar sponsor and CE provider, Eating Recovery Center. And I will now introduce the speakers, and then just before I turn it over to them, I'll go through a couple of housekeeping notes. Casey Talent is the Director of Collegiate and Telebehavioral Health Initiatives for ERC. She co-founded ERC's virtual IOP program in 2017 and has expanded those services nationwide while developing ERC's virtual PHP program in response to the current pandemic. And Jenna Tregarthen is the CEO and co-founder of Recovery Record. She's interested in designing and evaluating technologies that increase access to and improve quality of eating disorder care. She conceived of Recovery Record, which she'll be telling you more about in a few minutes, while undertaking her PhD in clinical psychology and lecturing in healthcare innovation. So they will have some great perspective. What's really cool about this is they've been doing telehealth for a while now, and they can offer their perspective on how it's been going, given the recent rise in telehealth, but they can provide some longer term perspective. So we're really looking forward to that. Some housekeeping just before I turn it over to them is that during the webinar, you're welcome to type any questions you think of into the question box throughout. ANAD will be monitoring those questions, and then the last 15 minutes will be reserved for those where we will pose those during the last 15 minutes. And our speakers have graciously offered, if we run out of time, we'll pull together a Q&A document that we'll send out to everyone next week. All of you will be muted throughout the broadcast, but if you have any issues, you can type it into your chat feature, and we'll do our best to help. After the webinar, you'll receive 2 emails. This afternoon, you'll get an email from ANAD with the slides and the recording. And by Tuesday morning, you'll receive an email from ERC with a link to the evaluation and an opportunity to download the CE certificate. So with that, I will now turn it over to Casey to begin our webinar. And thank you both for being here.
Thanks, Lynn. All right. So I'm going to kick us off today and then pass it over to my colleague Jenna. And we're both going to be talking about telehealth interventions for eating disorders. Do they really work? I'm going to kick it off by sharing a little bit of a review of the literature. I'm going to talk about some preliminary research outcomes from the program that Lynn talked about that we started in 2017. And then I'm also going to talk about being an informed consumer of telehealth for eating disorders. So first, I want to start with a little bit of the history of telehealth. It's hard to kind of see where we are now without examining a little bit about where we've come from. So first, when we talk about telehealth, I'm really talking about, I'm really talking about the use of electronic communication and information technologies to provide support, to provide or support clinical care at a distance. So there's lots of names for this. You might hear it called telemedicine, telemental health, telebehavioral health, e-health. I'm going to use these terms a bit interchangeably today. I apologize in advance for that, but they're all describing the same thing. Okay, so barriers to care. One of the things that's important to think about when we are looking at telehealth is how many people in general are not accessing care. Estimates are between 50 and 70%, but it's really impossible to know how many people are not accessing care. We know that there's disproportionate numbers of people accessing care based on gender, race, ethnicity, SES, geography, health status. And particularly with eating disorders, we know that eating disorder, expert care for eating disorders is extremely limited, and only a small subgroup of individuals affected by an eating disorder ever seek appropriate professional support for that. Treatment seeking behaviors we see tend to increase with age, but this might not be true after a certain point. So when we look at comparisons of if telehealth is working, and particularly when we look at comparisons from in-person care to telehealth, oftentimes it's not the right measure because we're missing all of those people that aren't receiving care that can then access care via telehealth. So when we look at the introduction of telehealth, I like to kind of put it in a couple timelines. So when we think about the invention of the telephone to, in its different forms, all the way to computers, to phones, to apps, there's certainly been a huge rise over the last decade, really, and century in telehealth. So it's kind of amazing when you look at actually how early telehealth began. The conversation started soon after Alexander Graham Bell placed his first call. And then I'm not going to spend a lot of time going through this timeline, but it's really interesting that in 1906, we had our first ECG transmission. I'm from Nebraska. Well, I live in Nebraska. So I think it's really interesting that in 1955 and thereafter, Nebraska, the University of Nebraska and then the Nebraska Psychiatric Institute used closed circuit television for telepsychiatry, which was very novel at the time. All the way down to Mass General providing services at an airport, NASA initiatives, connecting remote villages in Alaska and Canada. In 1989, the first patient was successfully defibrillated by telephone. In 2005, Skype and video chat were booming. And then in 2020, telehealth is expected to be a $34 billion industry. And that has probably only increased based on the response to coronavirus. So certainly we've seen, pretty steady growth in telehealth and bringing healthcare in general to more people. So when we look at telehealth acceptability, we find that 76% of patients report that access to care is more important to them than physical contact. So people want care, and that's what's most important to them rather than being in close physical proximity to their providers. So kind of looking a little bit more in depth at the literature, I will say that there isn't a lot of research looking at telehealth with eating disorders. There's a few kind of hallmark studies. There are a lot of research studies looking at telehealth for anxiety, depression, mental health in general. And so what I did is I looked at kind of all of those. I looked at telehealth literature across mental health as well as specific to eating disorders. And Jen is going to talk more about some additional literature focusing just on eating disorders as well. But when we look at these, there's a lot of meta-analyses. And what we find is that the acceptability has been really high overall. We see improvement of symptoms and quality of life with telehealth, and that's across mental health diagnoses. Telehealth makes care more accessible, convenient, and cost-effective. We do see that the preference for a modality impacts the effect. So if you don't think telehealth is going to work for you, you're not interested in it, it's probably not going to work for you. It's very similar to if you step into a therapist's office and you're completely resistant to not open at all, it's probably not going to work for you. So we see kind of a similar effect there with telehealth. Some studies show that dropout rates in telehealth remain concerning. I'll share with you a little bit about our research, some of our preliminary data, and we found the opposite. High utility, there's a high utility for early intervention and secondary prevention through telehealth. And we do see that sometimes challenges can be present with the diagnostic process. So getting heights, weights, vitals can be challenging. Sometimes those things that healthcare providers are just accustomed to doing in person can be difficult to do via telehealth. And then uncertainty in the field about how to blend care. So there's some research looking at, this combination of facility-based care or in-person care and telehealth, and how to really blend the two. What we see in some of that research is that they are taking an individual and they're maybe one person on their own is engaging in a group of like 10 people in a center, and that seems to be not that effective. We also see that telehealth for relapse prevention can be very promising, and used in a step care continuum, it can be incredibly cost effective. So the research is overall very positive with the use of telehealth for mental health and for eating disorders. Some key benefits of telebehavioral health is that it actually brings treatment to individuals instead of individuals having to go to the treatment. It utilizes, when you utilize telebehavioral health methodologies, we can reach individuals who are limited by barriers. So for most of my career, I worked in college mental health, and I certainly saw those barriers. Many of you are probably familiar that a lot of college towns don't have many resources. And so I certainly saw that when I ran an eating disorder treatment team on a college campus, that the options were us, the college treatment team, or going away 8 hours to treatment. So telehealth actually provides a lot of options for healthcare that aren't available otherwise. It also allows individuals to enter treatment earlier in the course of the illness. When I'll talk about our research a little bit, that's exactly why we developed the virtual IOP program a little bit over 3 years ago, was to try to catch people earlier so that they did not need a higher level of care. And it also allows individuals to continue treatment in rural and underserved areas when they return from a higher level of care. And it just stops the process of individuals not being able to access care. So I'm going to talk a little bit about the research that we've done. So we did a research study with about 57 participants. 45 completed all of our research. And so what we did for those participants is they were in our virtual IOP program. So they received three 3-hour group sessions weekly with a licensed therapist and a registered dietitian. And they received therapy groups, meal support, as well as nutrition group. So 3 meals a week, supported by a dietitian or a therapist, and then 6 therapy groups a week. They also received 1 hour of weekly individual or family therapy with a licensed therapist, and bi-weekly sessions with a registered dietitian. And they also used the Recovery Record app and had access to that 24/7, which Jen is going to talk more about. So when we looked at if this was effective or not, just a quick little stats lesson, we find that we look for effect size. So if you see a medium effect size or a large effect size, that means that that this is effective. So we want to see the medium or large effect sizes. What we looked at is we looked at self-esteem, depression, binging, purging, restricting, and eating disorder quality of life. And what we found is that patients in the virtual IOP program significantly improved. So they had medium to large effect sizes in every category, with effect sizes ranging from, as I said, medium to large. So you can see in particular, depression, binging, purging, and quality of life had large effect sizes, as well as restricting, and then self-esteem had a moderate or medium effect size. We also looked at patient satisfaction. And so what we found is that patients liked this virtual treatment. So on a 1 to 5 scale, where 5 was strongly agree, you can see that most individuals, for everything except for discharge readiness, were between strongly agree and agree for total patient satisfaction, treatment satisfaction, and environment satisfaction. Discharge readiness was slightly below agree, only because as part of this research study, participants only received 6 weeks of free care in the study, and then they were referred to other care after that. So we had patients who would have liked to have stayed longer, who received referrals. When we look at patient satisfaction highlights, you can see that patients really liked it. Sorry, my slides are advancing on their own. So you can see that 98% agreed that they were able to utilize video conferencing technology effectively. We did have an age range from 17 to late 60s. And so we were really happy with how comfortable people were in that age range with video conferencing technology. 98% agreed that it was a recovery-focused environment. 100% felt connected to facilitators and group members and agreed that staff treated them with respect and dignity. 96 believe that after discharge or transition, they'll put the skills that they learned into practice. And 96% also felt that treatment had increased their chances of improving their health. So these are really patient satisfaction measures that we want to see in any kind of treatment. And so seeing them in a virtual treatment certainly dispelled some of the myths and dispelled some of the criticisms that I think virtual treatment oftentimes receives, particularly connection. Patients felt incredibly connected to one another. And this went all the way from when we first started this program, we did a quick qualitative study. I'm a qualitative researcher. I love qualitative research. And we found themes of connectedness, support. And so we got to see that kind of all the way through the research. we have just resubmitted this for publication, and so hopefully this data will be out soon. So I'm going to switch a little bit, and I'm happy to answer any questions in the question section about our experience conducting virtual, as well as any questions about the virtual PHP program. But I want to make sure that we're leaving everyone with tools to know how to be a good informed consumer of treatment. And if you're a treatment provider, I want to make sure that you can answer these questions for your patients as well to provide them with the best platform possible. So these are some questions that for all the consumers, or for all of the family members or those seeking treatment, I would like you to consider when you're looking for telehealth for eating disorder treatment. So first, is the platform safe and secure? And I'm going to go through each one of these. Has the staff had specific training in telebehavioral health? Are providers licensed to provide services in my state? And does the program provide meal support? And how are weights and vitals monitored? And then will I be surveyed about my satisfaction or experience in the program? Do people want my opinions? And then finally, what's the structure of the program? Does it include individual therapy and individual nutrition therapy? So to address this first one, virtual platform safety and security, and I think Jen is going to talk a little bit more about this, or may talk about this later as well. So what you want to make sure is that people are using fully secure and HIPAA compliant platforms. So you may have seen that in light of this crisis, there has been some lifting of restrictions for telehealth platforms. So essentially what that means is that HIPAA has said that the Department of Health and Human Services has said that they're not going to enforce HIPAA violations for non-secure platforms. So providers can use Skype or FaceTime, but unfortunately, those are not secure and HIPAA compliant platforms. So I certainly don't recommend that you engage in care using those platforms for several reasons. One is that your data is not protected. They're collecting user data on those sites to show you ads, to show you other information, and so your data just simply isn't protected. They're also not encrypted. So what you want in a fully secure and HIPAA compliant platform is to have no chat feature, no record feature. You only want to know first names of any other group members. You don't want any collection of user data, and you want it to be encrypted. I should have included that here. So you want your data to be encrypted. And for providers, they also need to have a business associates agreement with the virtual platform company that further protects the data and information of all patients. So no chat, no record, only first names, encrypted data, business associates agreement, and making sure no collection, user data is not being collected and used or sold by the companies. Therapists also, as part of safety, have to confirm the physical location and emergency contact information of patients at every point of contact. So in order to ensure safety, you have to make sure that the patient's located in the state in which you're licensed to practice. And you also have to make sure that you have, as a provider, all of the safety information that you would need for that patient. So local police numbers, local hospital numbers, emergency contact name and numbers, so that you can fully protect that patient. And as a patient, you want to make sure that your providers are getting that information as well in case anything were to happen. Telehealth training. So as an informed consumer, you want to make sure that the people that are providing your services have received telehealth training. So it is a little different providing telehealth versus providing healthcare in person. One example of that is in telehealth ethics training. You're taught not to comment on the space around you. So you can certainly see more into someone's life when you see into their house when you're providing therapy with that individual. But telehealth ethics trains you not to comment on that your relationship is still with the patient, with that individual client. And so you don't want to comment on those things. You learn just a wealth of information in extensive telehealth training. You want to make sure that providers are trained on law and ethics of providing telehealth services. If they're not, they're likely to make mistakes that we just covered on the last slide. They're likely not to have HIPAA compliant, safe, secure platforms and to be doing everything to ensure the safety of patients because they simply don't know. So you want to make sure that they have the training and they're doing that. All staff also must be licensed in the state in which they're providing services. So both for patients and professionals, you want to make sure that you are protected to practice in the state in which a client is physically located. You also want to make sure that teams are collaborating with local community providers. I'll talk about weight and vital monitoring in just a little bit, but traditionally with telehealth, you want to make sure you have a local community provider that you're partnering with that's monitoring weights and vitals and those kinds of things during eating disorder telehealth treatment. So as I said, licensed providers. So healthcare in the United States takes place at the location of the patient or the client. So if you know, for example, college students are always confusing to providers. So you may be a resident of Louisiana and be attending college in Texas. And so you have to be treated while you're attending college in Texas. You're physically located in Texas. So your provider has to be licensed in the state of Texas. You cannot see a provider from Louisiana just because you're a resident there unless they are licensed to provide care in Texas. So this protects you as the client. It also protects the providers and individuals because we simply can't practice outside of our license. Okay, meal support. So you also want to make sure, meal support is really critical to eating disorder care. So you want to make sure that meal support is included in any telehealth IOP, PHP program that you might be interested in. You also want to make sure that registered dietitians are providing those, the meal support, are helping to tailor meal plans, are helping with meal monitoring. And supportive apps like Recovery Record is really key to being able to adequately have online meal support. So an example of that, when we were developing our virtual IOP program, we tried lots of different ways for meal monitoring and to have the meal groups together. So as Karen Schneller and I were developing the program together, we would sit down, we would eat together on the platform, and we would try all these different things. So we would like hold our plates up, all the food would slide off. We would turn our camera and then our camera would fall. So we tried all kinds of different things and they just don't work. So what we landed on, and you'll be hearing from the genius mastermind behind it, is Recovery Record. And so through Recovery Record, patients simply take a picture of their meal. They hold their camera up, take a picture of their meal. The therapists and dietitians get live access to that. And so if they need to encourage a patient to, add an exchange or something, they're able to do that. And then at the end of the meal, they take another picture with their Recovery Record app, and the clinicians have live access to that. So you want to make sure that there's an easy workable way of having those meals together. Weights and vitals. So programs, one thing that I think some people don't know, and that's important to know, is that programs that take insurance have to monitor biweekly weights for weight restoring patients and biweekly vitals. So if you are using insurance for a program, then there has to be a way of gathering that information. And so my recommendation would be to really talk with providers to work out a weight and vital monitoring plan that works for your situation. So we have about 4 contingencies that different patients can use based on what's available to them. And so you want to make sure that there are options that would work for you. Patient surveys. So you want to make sure that you're selecting a program that does care about your experience, that is gathering information about satisfaction and outcomes. For example, when we developed our virtual PHP program recently, we asked all of our patients at the end of each session to complete a survey, because we want to know exactly how patients are feeling about the program, what's working, what's not, so that we can make quick changes if we need to. You can also ask for any outcome or satisfaction data that a program has gathered to be able to see that for yourself. So I know patient surveys can sometimes be annoying to have to fill out surveys, but they are so important for programs to really be able to monitor how things are going and make changes that improve the outcomes for patients. And finally, the structure of program. So you want to select a program that provides group experiences and meal support. We know that both are incredibly important for eating disorder recovery. Group experiences are challenging, as is meal support, but both are really necessary in recovery. You want to select a program that includes weekly appointments with clinicians and dietitians. Ask about the layout of the program. Make sure that you'll be able to see everyone's face and hear everyone. So that description that I discussed from the research earlier, the concept of where you're one person and you are, being video conferenced in to a group that's happening in person, it just doesn't work, is what research tells us. It doesn't feel good. So that's something you want to make sure that you can clearly see everyone's face and hear everyone in the group. And you also want to make sure that everyone has headphones on for confidentiality. So these are some questions that you can certainly ask programs. You might not be able to get an answer from somebody on an assessment line, but they can certainly get you to somebody who can answer these questions for you. And I think as you're looking at different programs, ask some of these questions, look for this information to be provided to you from some of these programs, and certainly do not hesitate to ask about your information being protected, about what the platform looks like in terms of confidentiality and privacy. It's so important for everybody to make sure that confidentiality, security, privacy is included for you to feel safe being vulnerable in therapy. So as I said, I'm happy to answer questions after Jenna has presented. And so now I'm going to pass it over to Jenna so that she can finish her presentation.
Okay, Casey, thank you so much. I love hearing you present. And for those who are tuning in, we are so lucky to have Casey as a field. As she's been talking, the level of diligence in making decisions that are in the interest of patients in every aspect of the program is incredible. And that, what we're seeing right now is a surge of treatment centers going online very quickly. I think it's so important now more than ever as consumers to be asking and requiring of them the same level of standard that Casey described. And now more than ever, your voice as a consumer will be listened to, because if they're hearing that patients are informed and are requiring these things, they're much, much more likely to make decisions in programming that reflect a high level of quality. So you're shaping actively a participant that's shaping the quality of care being provided, and these considerations, they're very real. It can be scary as a provider to collect patient feedback forms or outcomes, because you want to stick your head in the sand and hope that it's all going well. But without that information, there is so much that says that providers who collect results get better results. And so if your treatment provider is not evaluating outcomes or patient satisfaction, then they're not learning and evolving and improving the care that you're receiving. So, and just one more kind of word on HIPAA compliance. I've heard so many people over the last couple of weeks, practitioners and consumers, to say, well, who's really going to be interested in my therapy session or my work with my client? That these hackers might come and get the data. It's not going to happen. But there's something that's happening instantly, which is that, on these platforms that are not secure, they're generating their revenue through selling your metadata. So even a verbal session, the metadata is being captured and sold to advertisers right then and there. So within an hour of being in a session, Facebook and Instagram might be sending you dieting commercial, advertisements, in different programs. It's spooky. So, HIPAA is this, it sounds really kind of boring, like this policy, but it's really there to ensure that technology platforms like Recovery Record are giving that business associate agreement with a provider, which basically says, I am legally obliged to uphold these incredibly high standards of data protection, and I'm on the hook for that. So that's what that BAA is for. Anyway, so I think it's such an exciting time, because, we saw the timeline for telehealth, and for decades there, the level of uptake of telehealth was the same, or it didn't change. Once we reached a certain threshold, it wasn't changing. Whereas right now, it's rapidly evolving and changing. It's something we're all actively participating in, which is exciting. But we also have a chance right now to shape the future direction of that. Anyway, so that's my soapbox moment. Thank you, Casey, for everything you've done for the field and for being here today to share that information. I'm going to pivot a little bit now into adjunctive technologies. So, telehealth, as we've just discussed it, is really about those sessions that are on a virtual platform, as well as the group components and what a dynamic program on telehealth looks like. But, and in the eating disorder space specifically, there's only been one randomized controlled trial completed in telehealth that was wrapped up and published only last year, actually. But it did show comparable results to in-person, by and large. And the authors essentially concluded that the two methodologies were comparable, and that was a fairly large trial. I think it was 150 participants. But there has been a lot of research looking at adjunctive technologies or platforms for self-help, for guided interventions, and on the recovery platform as well. So I'm going to open up and share with you now a little bit of a deep dive into the wonderful world of using technology to support day-to-day recovery. So I'm going to share my screen with you now. Let's see. Okay. Oops. Is that sharing? Okay. All right, I believe I'm screen sharing. Let me just double check. Yes,
yep, it's perfect.
Okay, thank you. Okay, so just quickly, Steffi Bauer has been one of the most prolific authors in the eating disorder field looking at telehealth for a long time, and that harks back to this 2013 article, which is still relevant today, where she summarized an overview of the landscape and essentially concluded that, look, there is sufficient evidence that e-interventions, really can serve to support and complement existing care, and there are those advantages that, Casey's already described there. But interestingly, there was a recent, to the point about access, and providing more frequent check-ins and progress reports, and accessing and reaching populations that don't traditionally receive treatment. My gosh, it is so true. And actually, there was a study that was published this year, and this is amazing, the research that's coming forth so quickly to learn in the current landscape, with almost 1,500 people. And interestingly, amongst other findings around acceptability for telehealth, I pulled this one out because those with higher levels of self-stigma were more likely to endorse a preference for e-therapy. So what that means is that, there's a population, we've always spoken about accessing stigmatized people experiencing stigma, and, this really is coming to fruition now, where people that really are feeling the burden of shame and stigma associated with the eating disorder so acutely that otherwise wouldn't go to, and that it's too much and too hard to go to that in-person session, are showing up, and, we're reaching this population that otherwise, just wouldn't be ready to, have that level of commitment for treatment. And I think it's really stretching our thought around this stepped model of care and the care continuum. I heard someone talking the other day about, even in groups, some people, if it's too triggering for them, might go and switch into a listen only mode. Now, of course, different programs would have an expectation for full participation, but there are different gradients, and there's a lot of nuance to the level of participation in treatment. So I think that's really exciting. But I want to talk about this last point here, which is about opportunities for augmenting treatment, and for self-monitoring. So fact is, in recovery, you need a tool that's right there in the moment when you're experiencing that, physical discomfort in your body, or those thoughts that are bombarding you, or that emotion that's so overwhelming that, you can't think of a different way to cope other than through, eating or exercise, or those different outlets that you use. So it's really hard not to look to the smartphone. Our smartphones now have more compute power than the technology that was used to put Curiosity on Mars. So we have this powerhouse machine in our pockets, but also we're using them at restaurants. The number of text messages we're sending per day is skyrocketing. It's our preferred, most comfortable method of communication oftentimes. And interestingly, one of the big medical search engines online found that more people are searching for, looking up mental health conditions and stigmatized health conditions on their mobile device versus their desktop. So there's definitely a sense of privacy. I've said false privacy because privacy, whether the data is secure is another thing, but there is a sense of privacy on a smartphone, which, otherwise isn't offered. And, thinking about, if you're someone who's in recovery that's joining in, or if you're a treatment provider, think about whether you've used a calorie counting track, MyFitnessPal, or if a fitness quantification app that's driving you toward a certain BMI before. This can be one of the main proponents of continuation of an eating disorder. It just drives that eating disorder in a way that is incredibly destructive. The reality is, we did a survey actually of 300 users, and 75% said they'd used a calorie counting app. I have a feeling it might be higher now. That was a little bit old, that study that we did. But I really asked this question to kind of really put to you, if technologies are being used in any case, and they're such an interwoven part of every aspect of our daily life, we as a field need to decide, do we want to say, don't use that app, but you can use this app, and go with that preferred methodology, or say, don't use any apps at all. And that was a part of what was the inspiration behind Recovery Record, was a desire for a really beautiful user experience and a great technology that was supportive of recovery when there were so many apps out there that were quite destructive. Now, like what, the homework gets such a bad name, it gets such a bad rap. It's one of the unsexy parts of treatment, like the paper-based homework. And it is, we have over a decade of research that shows that there's a link between homework adherence and outcomes. And there's a couple of select studies that I've pulled out here, but truly, we do know that compliance with DBT diary cards or those cognitive behavioral meal monitoring forms, or if it's ACT-based work and you're looking at the skill completion, is associated with better outcomes. And there's a couple of reasons for that. Fairborn's manual for CBTE treatment of eating disorders spells out a couple of them. And the number one reason is really awareness. If you don't understand a problem, it's very hard to change the problem. And eating disorders are so nuanced and deeply personal that the only way to really understand what's happening, and if you have an eating disorder, it's hard to really distinguish like what are all the factors that are contributing to an episode. So this allows us to unpack that. And so the treatment team is able to get up to speed with what's actually happening around the event in terms of were there any triggers present, what was the emotions, thoughts that were present at the time of the meal, what happened that drove those choices. And cognitions. So, and for those that are having a lived experience, it's exhausting recovering from an eating disorder, and a lot of folks just want to create as much distance as possible from that distressing and sometimes traumatizing event. And so the temptation is not to reflect on it or monitor it or even become aware of it and to kind of block it out, and it's so understandable why that phenomenon occurs, but this process of self-monitoring brings us into a level of consciousness again of what's happening. And that's for that reason it's really hard to do this work initially, but we know that it is the first step toward that awareness and then making some changes. And in that, on that note, it does actually help routinize regular eating. One of the core principles of recovery is having regular meals. And if you're monitoring, you suddenly become so much more aware of the meals that you skipped, or the gaps between those meals, and so does the treatment team. And the process of self-monitoring is actually a part of meal processing that Casey mentioned before. It slows things down so that you get out of that autopilot chain of events and break the chain. So to stop, to process, and it actually takes on average, I think it's like a minute and 5 seconds to do one of these entries. So it's not that much time, really. So like less than 10 minutes in a day that's committed toward recovery and doing this process, but it creates this pause that allows thinking about a different coping strategy to use and how to respond. And sometimes an urge will subside in that time as well. But the last point to make on this note is that it allows us to, and this is a little bit more speculative than the research, but it allows us to accelerate the therapeutic process, because if a treatment team and a patient are getting that insight into what's happening in the first few weeks of treatment, as opposed to suddenly realizing that in month 3, then we can move a lot faster toward really effective therapeutic work. That's important because we now know that if treatment has effectiveness earlier, the likelihood of it being effective in the longer term is much higher. So this is the tried and true pen and paper method that I actually tried to do this. I was when I was training in clinical psychology, I tried to do the homework that I was asking my clients to do, and I couldn't. It's really hard to remember to do this. It's all looking back up at you from the page once you've written something down. If you're pulling it out in public, it'll draw attention, the sight of a pen and paper these days. So and there's actually a study by Stone et al., which has been replicated a couple of times, where they gave patients a book to do their self-meal monitoring, and they embedded a sensor in the cover so that the researchers knew when those patients were opening the book, but the patients didn't know that they knew. So it was a blind study. And then they asked them to monitor their meals for a month. And then at the end of the month, they asked those participants to self-report how many times they managed to record their meals in the moment, and they said it was around 90% of the time, but they looked at the sensor and it was actually 11% of the time. So, and I don't think it's that those participants were particularly deceptive. I think it felt like they were doing it so much more than they actually were, but also it really proves a point that we're not getting that with paper. Folks are not completing it in the moment, and therefore we're losing the opportunity for therapeutic intervention, and we're losing this valuable data. And we've already spoken about why data is so important in the treatment process. So unfortunately, there's really 3 apps that I'm aware of in the for eating disorders. One which is not HIPAA compliant or used in clinical treatment and has had no research evaluating it. Actually, no, it was evaluated in one study that looked at evidence-based components and found that it did not have evidence-based content. Another one, I Take Control, from Drexel, which is focusing on binge eating, and I'm not sure if it is publicly available. And I don't know a huge amount about that technology, but it's worth having a look at. And then there's Recovery Record. Because there's a lot of research now published on this platform, and it's the platform I obviously know well. I'm going to be talking about this platform, but full disclosure, I am a founder of the company. So I'm going to try and be as impartial as possible in this information. But the platform has 3 components. So this is it for patients. There's a completely free and HIPAA compliant app that can be downloaded from the App Store on iPhone, Android, or it can be used on desktop. That can be used in a self-help capacity, or it can be linked with any number of members of the care team. So the dietitian, primary therapist, psychiatrist. Usually it's a group therapist. Usually it's the primary therapist and dietitian who link. And then for treatment centers, there's an encrypted dashboard for accessing quality data and outcome data that can be collected. So just to give you a couple of an overview of the features, the main function is that cognitive behavioral meal monitoring that's completed in the app, the ability to link with a treatment team, and also there's over 200 coping skills that are available within the app, covering acceptance commitment therapy, dialectical behavioral therapy, and cognitive behavioral therapy. And the app surfaces those skills right after a meal has been logged, to give suggested strategies in the very moment. And then there's clinical goals. So there is a program of an 8-week program of sort of SMART style goals for recovery for the different diagnoses of eating disorders, specific measurable achievable goals. So little things that can be worked on each week. And then there's the opportunity for in-app feedback for practitioners for the care team to provide comments, give thumbs up, send beautiful affirmation images that are relevant to create that level of connection in the day-to-day. And for providers, this app is kind of like the dashboard for their caseload. They can see, and a lot of patients wonder, like, what can their provider see? And they're really seeing those log entries come through as almost like a Facebook feed, that the information's there. It's really quick to take a look at and get up to speed right before a session. So, and providers can see, can also set a treatment plan within the app, whether that's a dietitian setting the exchange targets or a plate model or a different meal plan for a client. They can set goals for the client's coping strategies. But really it's about having the information to provide really personalized treatment. This is, we're approaching the 1 million user mark, which is such an exciting milestone that our whole team is kind of waiting for and watching for. So it's really being used very broadly, and over 10,000 practitioners are now using the tool kind of routinely in their work. So, this is, I think that we're a very small company. We don't even have a marketing budget. So I think that the fact that the tool is being used this much reflects that there is a need for something like this as an adjunct to treatment. And it's not just theory or research, it's really being applied in day-to-day. But who are these nearly 1 million people? So to Casey's earlier point about, like, who are the people that we're not reaching, who are not in treatment for various reasons. A lot of them are using mobile technologies. 33% of our users haven't even told anyone they have an eating disorder. So if you stop and think about that for a minute, it's quite astounding, you know, that the first step for help seeking can be going to the App Store and finding something, which makes complete sense. So, and you know, but around 50% of our users are in some form of treatment. Similar to Casey, we've seen the whole age spectrum from 14 to 70. The platform's not appropriate for people under the age of 13 because of the child online protection policies, but we are seeing it being used in an FBT context with parents doing the monitoring using the app. But there is a large age range that we're seeing here. And actually, we have looked at this in a few studies, and we have not found a significant difference in uptake of the platform across the age groups, which is fascinating because a lot of people assume that younger users might use it more or use it more effectively. You know, a couple of studies, we actually originally developed the tool as an adjunct to treatment because I was personally very skeptical about whether, you know, an app could actually have a treatment effectiveness. And really, given the seriousness of eating disorders, I still believe that having treatment with a specialized provider is really important. But given that so many of our users did not have that treatment and access to that treatment, we thought that it was really important to look at, can the app be effective in treating people or having some intervention effect as a self-help tool. And it's completely free. So we had a National Institute of Mental Health grant and did a very large scale study and recruited almost 3,300 individuals who had users of the app who were elected into this study. Now, I want to point out that only 30%, well, only actually, depending on who I talk to, some say that this is an incredible number, but around 30% used the app for an 8-week period and completed all of the surveys. So I think that's consistent with what we were expecting, to be honest, based on the mobile health literature. Remembering these people haven't told anyone they have an eating disorder, are receiving no treatment, have no support. So it's really relying on their own internal motivation and accountability to keeping this up for an 8-week period. But those who did keep it up had some pretty great results. We had a tailored, sort of more personalized 8-week program versus the standard app, and both groups did receive overall significant outcome improvement. And the rate of remission at 8 weeks was higher for the group receiving the more personalized program. Interestingly, that time was a significant effect, and that's something that I think is going to be an ongoing question in the research is, how long should people use these tools? How long should a virtual IOP program be? How long should an app be used to get some treatment effect? And we did find that users were 12% more likely to achieve improvement for each week that they stayed in the program. So there was some dosage effect, but I think we really need to learn more about that. But then, you know, I mentioned that actually the intended use was using this technology in a treatment setting. And there was a study done with Northern California Kaiser Permanente where 300 patients in outpatient and an IOP setting used the technology, and then there was a matched control group that they looked at. And this was exciting because there was medical record data to look at here. And what was found is that the folks using recovery record did have significant outcome improvement in pathology, quality of life, and depression. And also, interestingly, people with low body mass indexes, so the underweight patients who were needing to stabilize weight, did have a significantly greater improvement than those in the control group. So that was unexpected because BMI is known to be quite a difficult thing to influence, and we didn't think a technology would necessarily do that, but it did. And I don't think it was the technology itself necessarily, but that the technology allowed patients to stay in treatment longer. So over a 6-month period, on average, participants attended 8 more outpatient appointments than the control group. So people using recovery record received more treatment, and they got better results. So there is something about that connection to care, and also potentially the accountability around the meal plan and the dietetic support in the app that allowed those patients with lower weight to have more stabilization. Okay, so the last thing I kind of wanted to say on the research here is just a nod to a lot of research in eating disorders and understanding eating disorders has been really hampered by small sample sizes. We're extremely committed to contributing to the science, and one of our research partnerships is with University of North Carolina and Cynthia Bulick and her team in the Binge Eating Genetics Initiative and the Anorexia Nervosa Genetics Initiative. And I think there's been a total across all the studies over 10,000 people recruited into clinical trials, and some incredible research being published as a result of that. So that's just a really nice, I guess, side benefit that's not often talked about in research of these platforms. So yeah, we're moving from care that was previously reactive to being more proactive with having more data to inform the care, from being, in these arbitrary 50-minute increments of treatment sessions to being more continuous, and it's something that's more aligned with what we know about behavior change, where it's in those coachable moments in the day-to-day that care needs to be received. And we're moving from more subjective to kind of more accurate information as well. And the system is incredible. Eating Recovery Center, for example, has a program where if a patient has received care, they're an used recovery record, and they step down to outpatient program, then outpatient providers can really easily link with the patient that they're receiving and access their historical data, provide ongoing care. So those handovers between levels of care, when patients are often really at risk. Folks are at risk because suddenly there's this transition in the support and the structure of the care that they're receiving that can be supported. And of course, for maintenance, I mean, a lot of folks on our platform are no longer receiving clinical treatment, but they're feeling like, okay, they might be starting to lapse, and they'll use a recovery record to remember and to continue doing the work that they were doing. There's incredible innovation and happening in a clinical level with the data. And this is just some examples of how data in recovery record can inform the treatment. Like, this is a thought log. I feel so confused and out of control. I did so well all day, and then tonight I just lost control. I don't know what happened. And so it's pretty, this is something that comes up quite a lot, is with eating disorder populations, especially those experiencing binge eating, that there'll be a pattern of restrictive eating and skipping meals through the day, and then for a whole host of reasons, in the evening, there'll be those binge eating events. And so this allows for a provider to kind of review those patterns and have a look at the data and to share that and have that kind of conversation. It also surfaces a lot around shame. I think the act of logging is really hard. There's an expression, going open kimono. It's sharing everything that's happening, which is can make someone feel very vulnerable and exposed. But the act of doing that and receiving empathy and being grounded is really powerful in overcoming the shame and stigma that keeps the eating disorder alive. So but also motivational interviewing, like what talking about the pros and cons, or talking about what's holding someone back. And then, of course, the photos that Casey mentioned, like learning how to eat again is really hard, and having a provider that's able to see your plate and your perception of what you've eaten, and then give you feedback on that, and examine portion perception and normalize, like, what is an adequate meal, is hugely powerful and therapeutic. And it used to be with paper diaries that patients were just writing what they'd eaten, which really just didn't give the full picture. So patients often have, but this technology is not without its flaws. Patients report having a fear of heightened preoccupation with food. I mentioned before, now, if you're not wanting to face into the eating disorder and now you're writing about what's happening, it can feel like the app has made you worse, whereas in fact you're becoming conscious of this, what's happening and the severity of the problem. And, so for providers, we often tell them almost that to advise patients that this may happen and it's okay, it's normal, and it does go away in a week or two. And so, you know, which again, that's one of the things that Fairborn noted in his manualized approach as a phenomenon that occurs. The other thing that patients struggle with, is treatment resistance. So this can be a wake-up call that they're not ready to let go of the eating disorder. That can be a really great opportunity for a therapeutic conversation about that. Again, the shame, I've spoken with that as well. This app has an incredible capacity to break through that. And, you know, actually some patients have said that like they could finally talk about something that was happening for them that they didn't feel comfortable talking about in person, but they could write about in the app. So that can be really exciting. But it's really important that practitioners have deep respect for this data and connect, normalize, and praise the courage to share. And finally, uncertainty about how the data will be used. So we actually have a patient agreement, which we share with practitioners, and it's important that that conversation's had up front about when will the data be looked at, how will it be used in treatment, will the provider be providing feedback or not. Otherwise, if you're a client who's sharing, you might be wondering, what does my therapist think? Like, you know, what does it mean if they comment? What does it mean if they don't? You know, did they see that thing that I wrote? So that can really take the ambiguity out of it. And for practitioners, this is a transition as well. They may feel like they need to be online all the time. And, you know, we have an out of office feature that gives office hours that really helps to maintain boundaries. The expectation is not that practitioners are on this 24/7. And providers need to be upfront about their availability. They may say, I'm not going to be commenting on your logs in the app. I'm just going to look at the data in session with you. Or, you know, I might be giving you feedback throughout the week, but it doesn't really matter what it is. The most important thing is that it's communicated and maintained. The other thing is questioning the accuracy of the data, and I just wanted to say that the app is not intended to be a complete and accurate representation of all dietary intake or behaviors. And in fact, for providers, if there's a day where there hasn't been any logging, you might want to ask about that day, because shame can surge, you know, during those periods and drive someone to distance themselves from recovery and treatment. So it can be important to ask about those events. The app is not intended to be used for suicidal, you know, reporting of self-harm or danger to yourself or others. Like with email, there's no guarantee that providers will see or respond to that. And users agree to those terms when they use the product, but it's important that practitioners reiterate that. And it's also reiterated in the app in the messaging feature where we remind users of that. Okay, so that brings us to the end of our presentation. I've ran over a little bit, but we still have time for questions, and I'm excited to dive into a discussion.
Chris, thank you, ladies, so much. This was, wow, you guys packed in a lot of information in a short amount of time, and we actually are fortunate to have about 20 minutes for questions and answers, which is awesome because we had a ton of them. So I've been compiling them into a separate document while you were talking, and I know for sure we're going to need to have a follow-up after this. So we'll go through a few questions now during the webinar, and then Casey and Jenna, thank you for agreeing in advance to receive a list of questions afterwards that you can type in your responses, and we'll send that out to everyone. Okay. So with that, we'll do a couple questions for Casey and then a couple for Jenna. Casey, if you can provide us a little more information on your studies. We had some questions specifically, are the results of the effectiveness and patient satisfaction, how did those compare to in-person programs? How do those compare with patients who started the relationship in person before transitioning to telehealth? Does that make a difference? And also, what were the treatment modalities for what you studied?
Yeah, so great question. We intended on doing a match sample study. And so we did compare initially. Well, we tried to compare to facility-based, and we ended up making it a pilot study kind of based on this because it was really challenging to find the match samples. So we didn't do comparison with this. We do plan on doing a follow-up study where we're comparing facility-based care to the virtual care. We felt okay about not being able to do that just because of this question of how many people aren't accessing treatment. The other question about, sorry, Lynn, can you repeat the second parts of this question?
Yeah, sorry. Yeah, about whether it makes a difference to have started the relationship with someone in person before transitioning to telehealth.
Yeah, so we, I don't believe any of the patients in the study were initially, certainly no patients in the study were initially patients of the virtual providers prior. So we haven't looked at that. It's a great question and something we'll look at in future studies as well.
Yeah. And then the last part is just a clarification of what treatment modalities you were using.
Yeah, great question. So
you were studying.
Yeah, so we used a combination of ACT, DBT, and CBT in the treatment. So we used our standard curriculum that we use in our facility-based IOP programs as well. So it's a combination of those three treatment modalities.
Yeah, cool. Okay, great. Can you recommend some trainings to learn more about how to offer telehealth as a provider?
Yes, there are some fantastic companies, and I don't have those pulled up right now.
Okay.
Maybe I can answer that one in the email and I can recommend some.
Yeah.
There's 4 or 5 companies that provide really thorough, excellent telehealth training, telehealth ethics training. And there's different price points for those, but all 5 of those that I can encourage are really great trainings.
Okay. Yeah, cool. Very good. How about any recommendations for parents who are stuck, patients who are stuck in an inpatient setting that isn't specialized to treat eating disorders and the limits of technology?
That's a good one, Jenna. You might be able to weigh in on that one too. So, I mean, I think that if you're not in a facility designed to treat eating disorders and you're looking for eating disorder recovery, I would encourage, I mean, I'm assuming you're there being treated for something else, substance abuse or mood and anxiety disorders, but I would encourage after that treatment is complete, transitioning to eating disorder specific treatment. I think there's several research studies that have found that certainly if you're being treated for something else while the eating disorder is primary, the eating disorder oftentimes gets worse during the other treatment. So eating disorder treatment is encouraged to be the primary initial treatment for comorbid concerns because it oftentimes gets worse if it's neglected in treatment for substance abuse or just mood and anxiety or personality disorders. So I would encourage somebody to that person to look into eating disorder treatment and also look at apps like Recovery Record and other things that they can use to augment their treatment to begin treating the eating disorder while they're in a different form of treatment. Anything you would add, Jenna?
No, I think that was a really fantastic response without knowing more about this person's circumstance. I can comment more broadly about technology use at different levels of care and app use at different levels of care. I think usually the focus of treatment at an inpatient level is around that medical stabilization and getting getting to a point of readiness to do some of the more the other therapeutic work, including the self-monitoring. So but that said, there are definitely programs, there's a couple of inpatient programs that are giving folks in recovery record to use to start to build on that work already and to start to do that work, and having access, especially when you're there around the clock. If you're sort of perseverating at night over something, and like, you know, that can be a time where those intrusive thoughts really flare, and distress and things start to feel really out of control, and having that resource to do, there's meditations built into the app to use the coping strategies. You know, there's no reason that you can't already access and start using those. So some facilities don't allow patients to use technology, have access to phones at that level of care. You know, I can say ERC's one of their programs that's really acute actually gives Android devices that have been locked down to clients so that they can have access to recovery record. And but, you know, obviously if social media is bombarding you, and when you open that, it can be highly triggering. So that's just another consideration, is access to the technology. If there's desktop computers that are set up, the patient portal can be used, and all of those resources are accessible on desktop as well.
Cool. Okay, yeah, sorry, we really have so many great questions. I guess this is a question for both of you, potentially for both of you, regarding access and people who don't have access to technology. What are the options?
Yeah, great question. So for people who don't have access, we've really found that oftentimes by getting creative, there can be access available. So libraries sometimes will check out devices, universities and schools will check out devices, and so if there are access to places or individuals where you can check out devices, that can also be helpful. I know we've had students, you know, go to a private room in the library so they could access programming there. So I think the other piece is oftentimes family or friends may have an old device laying around that could be accessed as well. So I think getting creative can oftentimes be really helpful in finding access to a device that can be helpful.
And the only thing I'd add to that, and I completely agree, like, not to let it be, you know, the barrier, because there are, like, those public spaces. The only problem with the public spaces, if you're logging in, is just making sure that the people that are around you can't, you know, see what you're doing necessarily.
Absolutely.
But if there's a problem with having a data plan, if you have got an Android or iPhone device but you don't have a data plan, the app actually has offline logging capability, so you can access still probably 80% of the content without having a connection. And then the next time you're in a Wi-Fi kind of hotspot, the data will load and sync. So it's not perfect, but it's something. And we actually did develop the desktop version of the tool, knowing that there are a lot of people who just don't have a smartphone. And in that case, as Casey mentioned, it's getting creative about how to access that. And it's possible you can put a passcode on the app. So if you were using someone else's device to access the tool, you can passcode protect it so that it's still secure on that device.
Interesting. Okay. All right. Yeah, those are a lot of creative suggestions. Okay, so let's now talk about geography, because now that we are in this world of telehealth, theoretically you can do it from anywhere, but there's licensing issues and insurance issues still. Okay, so we had some questions about, do dietitians have to be licensed in the same state that the patient resides in? And then some questions specifically about college students, like if a student is going to study abroad, what are the options? And then also if a college student is starting a relationship in the state where they resided, but then going to college in another state. So yeah, do you guys know anything about how this is working right now?
Yeah, definitely. So Dietitians are different. So some states do require dietitians to be licensed, some do not. Some states like Indiana specifically disallows dietitians to use telehealth. So I think every state has different regulations. Dietitians are regulated a little less strictly than other mental health professionals or healthcare professionals, but in many states, I think it's 26 states, they still have to be licensed. And oftentimes dietitians just have to write a note or write a letter, submit a form to a state that they're going to be practicing there. So I would encourage there's a couple dietitian organizations that have maps that have specifically information about telehealth practices in different states, where they can practice, what they have to do to practice. So I would encourage any dietitians to look there. In terms of study abroad, it's tricky for studying abroad. It depends on the country and what the regulations are in that country, if your practitioners can practice there. So I will say, I worked on a college campus for many years, had many students study abroad. I think there are some providers who make exceptions for that and who will, do a phone call or something with that student a couple times, during their study abroad experience. But for licensure, you do have to check in with the state or with the country that the student is studying in to see if you can practice there. So Australia typically allows anybody licensed in the United States to practice. Some provinces in Canada allow that. It really just varies country to country. So I would encourage your provider to reach out and see if they can practice there. For the last one, for college students who are starting a therapeutic relationship and then going away somewhere to college, unfortunately, unless that provider is licensed in the state that they're going to be attending college in, they likely won't be able to continue with that provider. They would have to find a new provider. It's not uncommon. A lot of people, develop new relationships with providers when they go to college. College counseling centers oftentimes provide fantastic care. They have phenomenal resource lists of providers in the communities who do really great work with students. So I think if you're needing referrals for the community that you're going to, reach out to the college counseling center, and they can let you know if you can be seen there or if they can provide you referrals in the community.
Yeah, that's great guidance for in-person support as well, Casey, to start doing that homework ahead of time before arriving on campus. So we do have a few minutes to get through some recovery record questions for Jenna. Just a basic question: is it HIPAA compliant? Is there training available? Is there any competition for recovery record right now? So let's get through a few of those basic ones first.
Yeah, sure. So we are absolutely compliant with HIPAA. We're also compliant with the High Tech Act. We're also compliant with GDPR requirements in Europe. All of that is a lot of acronyms, but it essentially means that we're doing more than is required of us. So the data is encrypted on the app itself, in transit, in our backend systems. Our team don't have access to the data. We don't partner with or sell the data or share it with any third parties, except for the provider who is being linked with, or the treatment team. And there's also passcode protection on the apps themselves. So we do a lot to protect the data. We do actually, the training is fantastic. I think individuals with eating disorders do tend to kind of pick up and run with the tool without much oversight. That said, we have got resources and materials that can be shared with folks in recovery If you wanted to email me, jenna@recoveryrecord.com, I'm happy to share those. But we do really incredible training for practitioners, because practitioners tend to need a little bit more support because there's quite a lot to the tool. And the first time you pick it up, it might be a little bit overwhelming. And I think some practitioners have this sense of that, that they're using the app in much less of a capacity than they could be, because they know that there's so much more to it. So the trainings are brilliant, and they generally give a whole lot of new resources to practitioners. So if you wanted to email either support@recoveryrecord.com or myself, I'm happy to help to set up those trainings. We usually do them for groups of practitioners, but we can make exceptions and do one-on-one as well. And we also have video trainings as well that you can access. And then the last question, I think, was, can you remind me, Lynn? I'm sorry. I missed that.
About the competition. Are there any competitors for you right now?
I kind of wish there were. It's, eating disorders is not an area a lot of people in technology are interested in getting into. There's a perception that it's niche, which just kills me. And we actually do a lot of work educating the technology sector as well as insurance companies about why they should be putting more resources into this population, because it is truly overlooked so much of the time. And I think that's starting to change, but no, but the answer is that no. Like I said, there's a couple of standalone apps that I guess could be viewed as competitive to our patient app. But honestly, I would encourage anyone in recovery to try a couple of different apps, so long as they are secure and evidence-based, and see what works for you and what is supporting your needs in recovery. And there are a number of virtual platforms, of course, that are delivering treatment virtually in different ways, but Recovery Record
looks like we may have
providers and delivered care in this way, and we decided not to, because we want the technology to be accessible to everyone. So in that way, we're usually a partner to, rather than competitive with, other treatment providers or platforms.
Yeah. I imagine that one issue with doing all of this remotely, and particularly an app around eating disorder treatment, could be how to deal with complete integrity and disclosure when it comes to patients sharing about their food intake. And so how does Recovery Record deal with that?
Yeah, and it's a question we do get a lot. Is this an accurate representation? It's so funny, actually, that someone posted on Twitter the other day that they couldn't believe the app had outsmarted their eating disorder, because they tried to upload a photo from a previous day, and the app says, sorry, that food wasn't eaten today. That that photo wasn't taken right now. So we actually only allow people to upload photos that were taken, we know the time of when the photo was taken of the meal. That said, we cannot guarantee that it's an accurate representation by any stretch. I think practitioners are asking patients to upload pre and post photos of their meal to get a sense of exactly how much was eaten. We also are asking about meal completion, as well as presenting if someone's going to upload has for example, an exchange target for a snack that's one carbohydrate and one protein, or whatever it might be, and then they upload the photo. We're actually going to ask, even before they eat their meal, what portion of their exchange target is being met in that meal. And so some people decide I've interviewed users of our app who said, well, just by getting that question, or knowing that their dietitian would see it, they made a different choice, and they added more to their plate, or because they wanted to stay on track in recovery. So I think there is that accountability there, which is incredibly helpful. But in terms of, and we do have an exchange tally, or and even there's a PDF for dietitians that says what was the meal planned versus the actual what was eaten, that we'll print that out in a really nice way. But it's not a complete representation. So if there's gaps, you should definitely be asking about the gaps. If a client, and this is where weighing is really important, if a client's reporting that they're having this incredible intake, but then they're still underweight and they're not gaining weight. There's a discrepancy there to ask the question, but also I think it's complementary to the other measures that you would take to understand intake rather than the full picture. However, it's a whole lot more accurate than other self-monitoring measures or simply asking in session about intake, that's for sure. But I think it lends itself to really fantastic conversations about perception of how adequate or inadequate different meals were, or portion sizes as well. So yeah.
Yeah, that's great. Very good. Yeah, it's it's not perfect. No technology is. No in-person treatment is perfect either. So, yeah, there's always got to be that caveat. I know we're at time, but I thought if people are willing to stay, I thought it might be cool to pose one more question to each of you. What is the biggest pleasant or positive surprise you have discovered in offering telehealth so far?
Yeah, I would say, yeah, I'll go first. I mean, as a clinician, as we were developing this, I think all clinicians are skeptical initially as you're approaching telehealth. Some of the questions I had as a clinician, were, is it going to feel as, are you going to feel as connected? Is it going to feel as personal as, sitting across from somebody in your office? And what we found, I mean, I think what's amazing is that it does. And what you lack for maybe seeing somebody's leg twitching, you make up for being able to see their eye quivering in a way that you couldn't across the room. And so I feel like that connection really comes through. It takes people, I tell people, give it 3 sessions to get used to, just like you would in person. And then you feel connected, you get used to it, and you can even capture so much more from being able to see people's face so closely.
Yeah, cool. That's great. Jenna?
It's such a great closing question, and there's so many wonderful things that have been surprising and amazing. It was definitely a surprise to me how many people would use the technology that hadn't told anyone about their eating disorder. Like, whoa, it's it's just incredible. But I think the biggest surprise is the way that the community has responded to that technology. I really feel like we're a partner with all of the providers on the platform, as well as the folks in recovery using the platform. We've had over 10,000 requests or suggestions for improvements to the technology or things that people would like to see it be able to do. And so that kind of spirit of innovation is what's allowed the platform to become what it is. Almost all the features are a product of people's ideas and needs, rather than, some idea that, my co-founder or I had when we were sitting behind a desk, and so I think that the innovation and just the way that practitioners are using the data and the tool in their own approach and bringing their own flair to it is incredible. There's just so much, that spirit of innovation, I think, is what surprised me, especially because it's such a shift in the way of working. That's pretty exciting. There's some fantastic work being done out there.
Yeah, and I think the lovely thing too about both of those, I mean, is just how many people are getting reached and are able to access technology to receive care that otherwise would never walk in or would never present, I think is just incredible.
And that used to be the theory or the promise of telehealth, that we spoke about, like some future thing that might happen, but it's happening now. It's happening now.
Right.
It's not just a theory. It's not just a promise. It's right now.
Right. It's no longer an option to experiment with telehealth. If you want treatment, that's how it's going these days. So, and I think, Jenna, your point about innovation and people being a partner in development and figuring out the best practices is really important to realize. This isn't a perfect solution right now, and it may never be. Neither is in-person treatment. They all there's pluses and minuses of everything. But what's great is that people seem to be rallying around this possibility and this potential, and being flexible and adaptable. And that's what we all have to do during this pandemic. So,
Yeah. I mean,
so
just one more comment on that, Lynn, because I think that
yeah.
what Casey's program and we have in common is constant iteration. And to any technology platform that has not released a new version in the last couple of months, I'm skeptical of, because any good technology is constantly evolving, and any good treatment program is constantly receiving data and iterating, and that's where that innovation engine comes in. And so yeah, I think it's just it's exciting to see where the future of our programs are going to go and how much better they're going to get. Yeah.
Right. Yeah. Well, excellent. Ladies, this has been such a pleasure. So much information. In addition to the thousands of questions we got, numerous people have already written in to express their appreciation of all the information you shared today. So thank you for this wonderful service and for all you're doing every day to make sure that people feel connected during this pandemic. And ANAD is right there with you too, offering our free support services. And, you know, it's a team effort, and we want everyone to know that there's no reason to suffer alone, and we're here for them. So, we'll close this out. We will follow up soon with the recording. It may not be ready quite today, but we'll definitely get it out to you early next week along with the slides, and then we'll follow up as soon as we can with answers to all your great questions. And in the meantime, have a great afternoon and enjoy your weekend, and stay safe, everyone. All the best. Thank you.
Bye.
Bye.
Bye.